Hello, 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 hello. Welcome everybody to yet another VMR. We're like edging closer and closer to VMR 1000. And I don't know what we're gonna do. I think we'll just like explode that day. Maybe that'll be the end of VMR. No, never, never. But it's a delight to have all of you here join us today. And we're graced by the presence of our beloved David, who lost 3 pounds over the weekend because he cut his hair. But has a really, really good case for us. Hi, David. You want to say hi?
Hi everyone. So when you want, I start.
Oh, you have to give us a life update though before you start. What's new with you, David? Give us some insight into your evolving life.
What is new is that I have a cold and maybe you can hear my voice a bit louder than it is. But anything more.
I'm so sorry to hear that. It seems like there's a cold traveling through the CPS virtual family with Sammy and now you. Who knew that Zoom could transmit infections? But I guess now we know. Well, I'm sorry to hear that, but thank you for making the time to join us today. So today you'll see that it's me discussing solo, but I would love to involve the chat. So we'll try to highlight as many comments as you have in the chat. So please keep your thinking. What I was thinking is to give you time to put your thoughts together in the chat. I'll just share my reflex thoughts to illustrate S1 thinking or rapid thinking, and then we'll lean on the chat to highlight some comments after I've reflexively shared some thoughts on David's case. Sound good? Okay, all right, David, take it away, my friend.
So the chief complaint is generalized weakness, dysarthria, and ataxia. I can give you a bit of the HPI if you want. This is an 84-year-old female who came 1 month ago to the ER, presenting with similar generalized weakness, but less profound than now. In the labs, they noticed that she had a pH of 7.2 with a bicarb of 31 and an anion gap of 14. They treated her with bicarb and discharged her after improvement. And now she came to the ER with disorientation, generalized weakness, dysarthria, ataxia that are progressive in the last 3 days. No fevers, no chills, no cough, no dyspnea, no chest pain, nor nausea or vomiting.
Very interesting, David. I just want to ask one clarifying question, which the bicarb is 21 or 31?
I think it's 21. Yeah.
Okay, all right, perfect. Thank you. So I think that there's something really interesting going on, which is that the patient has a combination of metabolic abnormalities and what seems to be symptoms consistent with brainstem involvement. And the brainstem involvement is evoked by the deadly D. So that would be diplopia, dysarthria, dysmetria, and dysarthria. She has two things. She has the dysarthria and the dysmetria, presumably. We haven't verified that this ataxia is cerebellar. It could also be sensory, but in the context of dysarthria, we probably would make the assumption that it is part of a brainstem syndrome, but that assumption is not perfect. So the real question is, in rapid thinking, is what is the overlap between an anion gap metabolic acidosis and a brainstem syndrome? And there are a few possible overlaps. There's the possibility that the patient has osmotic demyelination in the context of alcohol use, which can happen. Also within alcohol use, you can get toxic alcohol ingestion like methanol and ethylene glycol that can cause a dysarthria syndrome. There's a rare but important possibility of D-lactic acidosis that can cause a cerebellar and brainstem syndrome, though that usually occurs in patients with bowel issues. So I think in real life, since the overlap between ataxia and dysarthria and an anion gap metabolic acidosis is not something that is common, you probably would be analyzing these problems separately. And so the separate analysis would be, hey, is this person have an acute vascular event in their brainstem, an acute compressive event like a mass, or is this an inflammatory cerebellar or basal or brainstem disease? So I think those are the things that those are the rapid overlaps, osmotic demyelination, atoxic alcohol ingestion, or D-lactic acidosis. But in real life, I think we should probably slow down and do some slow thinking. And Yasmin, I think that you have some good thoughts here. I would love for you to share them out loud.
Oh yeah, thank you. When ataxia, normally I personally I start thinking if it's acute onset or it's a chronic onset or subacute. In this case, I think we could consider it a chronic onset. And in that case, we can think, well, maybe it's maybe an intoxication, a toxic neuropathy. Maybe she's exposed to, I don't know, lead or mercury, or if her is really old, I know that there can be any environmental exposure, or even there are other drugs and acute intoxications that are a little bit more just thallium or ethylene oxide, all this occupational toxins, but those are the first ones that come to mind.
I absolutely love it. I think the key things right now are just to understand that ataxia is either a sensory ataxia or a cerebellar ataxia. And I think all of us are assuming that this person has a cerebellar ataxia, though they could have a sensory ataxia. And yeah, I think in the face of metabolic issues, it's hard not to think about metabolic and toxins as the potential overlap. So I completely agree with you. I'm really curious to see where these things go. All right, David, tell us more, please.
Great discussion, as always. So, for past medical history, she had hypothyroidism on levothyroxine, AFib on warfarin and bisoprolol. 18 years ago, she had a rectal cancer she was treated with rectal sigmoidostomy, chemotherapy, and radiotherapy, and she had a colostomy after that. 9 years ago, she had an intestinal obstruction due to adhesions, and she had an ileal resection. And she also had CKD stage 4A1 with basal creatinine around 2.5, and chronic anemia, for which she was on B12 and erythropoietin. She also had a history of recurrent UTIs. No relevant family history or social history, or no alcohol consumption or smoking. I can give you the exam if you want. Or
Yeah, no, I think David, I think the thing that you've given us now is just to speculate on this past medical history. And anytime that you have thyroid issues and some neuro issue, you want to get a TSH. I think that's important. And here in the mix also is the patient has anticoagulation. So you want to make sure that the patient hasn't had any neurological catastrophe. But the most intriguing history is now that an anticipated piece of history, which is that bowel issues, has now come to the forefront. And the range of bowel issues that she's had means that she's at risk of a variety of toxic effects of bowel issues and also nutritional deficiencies. And nutritional deficiencies don't have this hectic presentation usually, except with the exception of thiamine. So when you're usually thinking nutritional, you think slow. But there are some nutritional issues that can be acute, like beriberi, or you can get fairly rapid B12 deficiency in the case of Whippet's use. So those are the only two nutritional issues that come to mind. But now you have to think of a variety of toxic effects, be it degalactic acidosis, as we talked about earlier, autobrewery syndrome, where there is auto fermentation of alcohol in the context of small intestinal bacterial overgrowth, and some very scary things. So the scariest thing would be that the patient has botulism, which you can also get an endogenous form of botulism from the growth of Clostridium in this very altered gastrointestinal environment. So long story short, the question now becomes, what is the overlap between metabolic acidosis, brainstem syndromes, and this GI history? And the only thing that is not yet clarified for us is, what is this really a brainstem syndrome, or is this a peripheral nerve issue? Because if this is a peripheral nerve issue and she has a few days of ataxia, dysarthria, and then I think botulism becomes an important thing to think about. If it's a brainstem syndrome, then I think you probably think more about D-lactic acidosis and autobrewery syndrome as the possible consequences. If she were altered or were confused, you might think about hyperammonemic encephalopathy or an elevated ammonia level. But I think we're thinking rapid here and already touching on rare things because of how unusual it is to have a few days of ataxia and dysarthria, and how rich this past medical history is. So far, to summarize, I think when you have a GI issue in the context of a neurological issue, you should really think medications and toxins and nutritional issues. Nutritional issues are usually subacute, not this hectic, but there are two acute ones, B12 and B1, in the context of Whippet use for B12. Medications, I don't think there are any obvious offending medications, and toxins can be things that people ingest or that your body makes by itself, be it botulism toxin, D-lactic acidosis, alcohol that you can make yourself, and ammonia. So I think that's what I'd be most suspicious of in this patient, but hopefully we can get more data to help us. All right, David.
Okay, so physical exam, temperature was 36.5 Celsius, blood pressure 19,943, heart rate 78, SpO2 95 on room air, respiratory rate 28, okay. In January, she was ill appearing, and the pulmonary was clear, and cardiovascular was arrhythmic with no murmurs. Abdominal diffuse tenderness, depulpation without guarding or rebound tenderness. She had left leg lower extremity mild edema, and for the new exam, she was drowsy, non-oriented in time space or person, and she had generalized weakness in all four extremities, and she had ataxia when walking, and dysarthria, but not aphasia, and the cranial nerves appear intact. Do you want me to give the basic? Okay. White blood cell counts 5,300.
I have a clarifying question about the exam. Did you test sensory, like the what's the sensory and reflexes?
Yeah, it was reported as normal. Yeah.
Okay. And the gait, did you do the gait? No, or she can't walk.
She was.
You didn't do the tandem. She can't do tandem.
I think she can.
Okay, right.
Hemoglobin was 9.3. Platelets 130,000. sodium 135, potassium 5.1, chloride 1.5, 105, so, glucose 135, urea 135, creatinine 2.7, baseline was 2.5. Yeah, the AST, ALT, bilirubin, and alphos were normal. CRP was less than 1. UA was positive for pyuria and nitrates and mild proteinuria. Yeah, and the venous blood test, she had a pH of 7.1. Yeah. Bicarb 13, PCO2 45, lactate 1.1, and yeah, anion gap was 18. Well, 17. Yeah.
David, this is clearly a very, very interesting case. And I think now that we have a lot of data, I think we can stop and slow down and analyze what we have. And we have a patient who's encephalopathic, who has focal signs. This is encephalopathy, along with features of brainstem issues. So now that she is ataxic when she's walking, I know it's hard to try to localize this exam with more precision about whether this is a sensory ataxia or a cerebellar ataxia when the patient is confused. It makes it very hard. However, if we were to make an educated guess, the fact that presumably her eyes are open and she's still wobbly suggests a cerebellar cause over a sensory ataxia. Most of the time when you have a sensory ataxia, the ataxia is more pronounced when the patient closes their eyes and no longer has vision to help them compensate for their sensory issue. So now I think we can confidently say that the ataxia is more likely cerebellar and fits in line with the dysarthria as a posterior fossa syndrome. However, this isn't just a posterior fossa syndrome because the patient's also confused, and that alone wouldn't line up with just posterior fossa alone, though there are cases when patients with brainstem inflammation who get impaired activation of their reticular activating system, and that can cause confusion. So where to go from here? I think that you have to hold that possibility that the patient has a brainstem syndrome, take it very seriously, because it could mean that the patient has, again, vascular catastrophe, a compressive syndrome, or a demyelinating or inflammatory lesion. And those are the first things you should think about. But none of them are in line with the metabolic profile of this patient, which is most in line with a anion gap metabolic acidosis. So what causes an anion gap metabolic acidosis? It's usually either lactic elevation, which we've ruled out here to some extent, ketones, uremia, or ingestions. So I see Shema is sharing a really helpful mnemonic. Shema, I don't know if you're able to unmute and expand on the mnemonic you just shared about anion gap metabolic acidosis. I know you may be in the library, but please tell us if you can. All right, I'm getting no worries at all, Shema. Sammy, since you're being credited for this and you made some points about D-lactate, do you want to unmute and share what your thoughts are?
Yeah, sure. When I think about Acidbase, I always think about Dr. Centaur, and he has this famous kill-you mnemonic that Shema just mentioned, and the K stands for ketones. I always think about, is this DKA? Is this alcoholic ketoacidosis? Or is this starvation ketoacidosis? The I stands for ingestions from iron over toxic alcohols, over paracetamol or salicylates. the alpha lactic acidosis, either is this type A or type B lactic acidosis, and you also have the D-lactate that doesn't get measured with the normal lactic acid value in the ABG, and the U stands for uremia, which this patient is also at risk for. So yeah, very interesting.
Yeah, 100%. Absolutely. Yeah, and I think if we're being precise about our thinking here, we're saying, okay, what we've ruled out L-lactate. We haven't checked for ketones, but the UA did not show them, so those are unlikely. Is there ingestions at play here? Possible. Is it uremia? Possible, but the degree of the anion gap elevation would be very unusual for this to be uremia. So I think the questions are, is there an ingestion? And the most important ingestion is a toxic alcohol like ethylene glycol or methanol. Or is this D-lactate? So let's take a second to explain what D-lactate is. You'll have to go back to organic chemistry, which is the only time that organic chemistry is relevant in medicine to understand D-lactate versus L-lactate. And they are what's called enantiomers. They are mirror images of each other. So I think a good example to think about this is to think about these two pens. So in many ways, these are the same pen, but if they're oriented like this in your body, they function very differently. If this is the left pen and this is the right pen, they exist in different pockets and different holes because they're fundamentally very, very different if they're fixed in this configuration. So if they're locked this way, they're very, very different. So different that their biological function is very different, and so different that one is not toxic and one is very toxic. So what is D-lactate? D-lactate is a product of a certain bacteria, namely lactobacillus. And the only time that you will have accumulation of D-lactate in the human body is when you have too much lactobacillus in it. And why would that happen? Is when you have short gut syndrome or small intestinal bacterial overgrowth. So this syndrome is very, very concerning for that possibility, and would be even more concerning if we got the history that carbohydrate rich meals triggered this symptom complex. Why? Because D-lactate is a product of metabolism for this bacterial lactobacillus. And so if this patient eats and then gets confused like this, that would be even more evocative. So what would I do next? I think that it would be a tough decision to think about whether we get an MRI for this patient, because again, these metabolic hypotheses take some time to prove, and the patient could have a posterior fossa catastrophe. So CT versus MRI is something to think about. But in this patient, I think I would specifically measure her serum ethanol to rule out autobrewery syndrome, which is the same issue, except that these bacteria aren't making D-lactate, they're making alcohol. I'd also send an ammonia level to make sure these bacteria that possibly in her gut aren't making ammonia as part of hyperammonemic encephalopathy. And then also just be open to the possibility that the other toxin, which is not consistent here, is botulinum toxin. The reason it's not consistent here is that the patient doesn't have any eye movement issues or pupillary issues, which are very characteristic of botulism. So yeah, those would be I think where my head would be at in real time. All right, David, tell us more.
So a CT head was done, and it didn't show any signs of bleeding or lesions. Well, an X-ray showed a small left pleural effusion without any opacities. And well, it was sent just one more test, and after that I'll give you the final diagnosis. Do you want me to give it to you? Yeah. Well, it was the serum osmolality that measured for calculating the osmol gap, that the osmol gap was 11. So it was no. And well, final diagnosis was, as Rabih stated from the first slide, was D-lactic acidosis due to small bowel syndrome. Short bowel syndrome.
So David, that's a really curious, very rare and very interesting syndrome. I've actually seen it once and never forget it. How did you measure the D-lactate, or how did you prove it was D-lactic acidosis?
I've seen this case. It was not my case. I've seen it in a society from Spain, but they didn't measure the D-lactic acid. They treated the patient with, well, they started with step reaction and bicarb, and she improved quite rapidly. So,
I
well,
see.
that was,
Yeah, wow, incredible. I think when you get the osmolar gap being normal, you've essentially made toxic ingestion much less likely. So by the process of elimination and in the context of this patient, I think it makes a lot of sense. Amazing case. So what did you learn from it, David?
oh, I've heard of D-lactic acidosis, but I didn't have that diagnosis in my mind, especially before reading this case, and I didn't know also that D-lactic acid was not measured in the usual lactate and blood test analysis. So I was struggling to make progress in the differential of the high anion gap acidosis, and well, I like it a lot because of that. Yeah.
Yeah, I think it's, yeah, I remember I saw it once as a second-year resident where a patient who had come into our hospital had short gut syndrome. She came in for other reasons, and then she actually after breakfast was found to be in a coma and was called a code stroke. And before she even got to the MRI machine, she woke up again. And I hadn't heard of that diagnosis then, but I was frantically searching about based on Google and whatnot, and Google's power is unbelievable. And I learned it from that case, saw her wake up afterwards. And it was interesting because I went back to her website, her bedside, and I saw that she had a box of Cheerios, like full, like cereal, milk, so on and so forth. So honestly, as soon as you presented this case to me, I got a little bit of flashback to her because there are very few things that cause an anion gap metabolic acidosis and a few days of dysarthria. That the DDX is very, very narrow. And when you have a very deep and powerful experience like that, it's hard to shake it. So I hope that David has done that for all of you, if you haven't seen it today, to have you imprint this very rare but important diagnosis in your mind. Really, really telling. Thank you so much. David, what would be one lesson that you learned that you want to hyper emphasize before we pass the mic to Joy for the teaching points?
Well, I think the biggest lesson is to make a good differential of metabolic acidosis in the sense of not forgetting any cause and well, trying to make progress first, knowing if it's high anion gap or non-anion gap, and when it's anion gap, trying to know what is ketones, lactate, or a toxic agent. And well, and I think it's cool to know also the symptom. But yeah, the approach to lactate is good.
I just want to commend you on that and also your outstanding case presentation skills. If you guys are watching David trying to put this case together, look at the first aliquot. He's essentially setting us up to have a good discussion by saying the two features of this diagnosis. He tells us the patient has dysarthria and ataxia, and he tells us the patient has an anion gap metabolic acidosis. He's not trying to trick us by like revealing the anion gap metabolic acidosis at the end or whatnot. He's setting it up for a rich discussion from the get-go. And that is a marker of a very advanced clinical reasoner and a person who's telling good stories. He knows that there are two key features of this illness and he's slowly building them up. So masterful presentation and I think a role model for all of us trying to learn how to grow our case presentation skills and set us up for a discussion. Really, really nice job. Thank you. Alrighty, Joy, we'll pass the mic to you for our teaching points.
All right, thank you for the case, David, and awesome discussion as usual by Rabih. So we had an elderly female who came in with a subacute, sort of like a subacute to possibly chronic type of generalized weakness, and the plus the dysarthria ataxia that evolved or associated with their weakness, and then of course they were altered when they were seen at the when they were seen at the ER or at where they were first when they came to seek help. So those were very good findings, clinical findings, to set us up to have a more focused look of where could this be. And we went on to the ataxia was very helpful, and so we went on to look at their past medical history, and there was that they did have some sort of a resection done there that caused them to have a short bowel, and then given they were an elderly female, and given their age, those also come into play as far as the most common types of like ataxia in elderly, that those peripheral neuropathies, distal neuropathies are quite common in the elderly population, and obviously we think of the most likely others like the metabolic, nutritional. We went on to think about this could this be a B12 deficiency, like a sensory proprioception DCM type of distal neuropathy, given their ataxia, and given the exam that was done here, they I simply did a Roomberg's test here, which was to the room when you have like Rabih talked about this earlier. When you have a positive Roomberg, it does, which was we found here that it does clinches the diagnosis. This is something extracranial, as we found out. And we looked at then we continued to look at their labs. So the big clue here is that they did have some anemia, but the big clue was the high anion gap and the past medical history, given their past medical history. So, and the other clues that only a seasoned clinician or Rabih early caught on was that they did have the D-lactate type of high anion gap, given the, so there is also a D-lactic or a high anion gap metabolic acidosis could cause some sort of encephalopathy, like the patient was confused, some degree of altered mentation here, and the other ataxia, that could be also explained in, like, if you have some sort of like problem around there in your basal ganglia, in your hypothalamus, you know, you could have that. Also, so this was I would encourage everyone to look into more of the etiologies of high anion gap, and obviously you just do math, right, with the anion gap or the normal gap, metabolic acidosis, but like the high anion gap is more rare than the we heard Rabih earlier, and the most common type that or etiology, such as in this case, was a short gut syndrome that this patient had. So that's all I have for you.
Yeah, thank you, Troy. I appreciate that. I will say this is a very, very complicated case. So going through it one more time, I'll try to share 3 teaching points with you, one from the beginning of the case, one from the middle of the case, and one from the end. So the first teaching point I would say from the beginning of the case was that it's really important to try to figure out if ataxia is a sensory ataxia or a cerebellar ataxia. And as Joy just said, the Romberg test is a test that can help you figure that out. Patients with cerebellar ataxia will be ataxic all the time. Patients with sensory ataxia will be particularly ataxic when they close their eyes. I think that's the first important teaching point from the first part of the case. From the second part of the case, I think that the most powerful thing that came in was a differential diagnosis for an anion gap metabolic acidosis. And that's where Sammy taught us the KLUI mnemonic: ketones, lactate, uremia, and ingestions. And I think in emphasizing that in the middle was really important. And then finally, the last part was, how do you combine the two? What is a differential diagnosis of an anion gap metabolic acidosis and cerebellar ataxia? And I think the most common overlap is either an ingestion from a toxic alcohol, ingestion from alcohol itself, or rarest of all is a D-lactic acidosis, which is a syndrome associated in patients who've had multiple gastrointestinal surgeries, and as a result of those surgeries form these colonies of bacteria, specifically lactobacillus in the case of D-lactic acidosis. So David, you've given us a lot of reading and reflecting to do, as Joy just said. I think we should all try to dive a little bit deeper from this rare and interesting case. But thank you all for your time, and we'll hopefully see you tomorrow for RLR. Bye.
Oh, there are